Hello, and thanks for joining us at Precision Medication Center of Colorado's short patient case scenario regarding blood pressure medication optimization utilizing pharmacogenomics. In this patient scenario, we can observe how pharmacogenomic personalized medication selection and dosing optimization can address drug interactions created by competitive inhibition between two or more medications. Let's meet our patient. This is a 66-year-old female on metoprolol tartrate who has noted lower blood pressure readings and lightheadedness after taking her morning dose of metoprolol alongside her once daily bupropion 300 milligrams, also known as Zyban in this instance as it is for smoking cessation. She is taking metoprolol tartrate 50 milligrams twice a day. There are two concepts to note as we optimize the medications for this patient. First and foremost, she has already undergone pharmacogenomic testing because of previously failed antidepressant therapy, so she went through this testing to tailor the antidepressant therapy to her genes. This means we now already know that she is a poor metabolizer of the cytochrome P450 enzyme CYP2D6. In her case, because she is a poor metabolizer, it is recommended to either initiate an alternative therapy such as carvedilol or bisoprolol that do not have this effect on CYP2D6 pathways, or reduce the dose of the medication being taken. In her case, the decision was made to enact a 75% dose reduction as long as she is on the Zyban. The reason we've done that is because Zyban and metoprolol are two medications that compete for the same enzymatic pathway and therefore will experience competitive inhibition happening here with the metoprolol. A useful analogy of this issue is traffic on a highway. The highway is our CYP2D6 enzyme and the cars are our medications. When there are only a few cars on the highway, everything flows fine and the cars get to where they need to go in a normal time frame, i.e., the medications that are taken have their desired effect and clear the body appropriately. But when we introduce more cars to the situation, everything gets bogged down. Adding a strong substrate for this pathway, like bupropion, is going to really block the metabolism of metoprolol and subsequently increase the experienced dose of the medication, even though the patient is taking the normal dose. A simple way to address this is just to reduce the taken dose. Please note that if and when the bupropion is ever discontinued, the dose of metoprolol will likely need to be adjusted once again. In a different scenario, let's say this patient was a rapid metabolizer, the liver would then be removing metoprolol faster than normal. In that instance, we would recommend an increase in dose because it's likely that normal dosing would not achieve an appropriate antihypertensive effect. It used to be that the package insert was about the only resource to guide pharmacists and prescribers on dosing with certain medications, and without pharmacogenomics, there was little adjustment to this. In today's world, we know that there isn't a single perfect dose that fits all patients, and there are instances where the pharmacogenomic analysis shows phenotypes that dictate higher or lower dosing. We hope that this has been a helpful case example for you from Precision Medication Center of Colorado.